Good morning, friends. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist, I have provided almost all the topics in a very systematic order. I hope this will be very convenient for the continuous study. And my dear friends, in the last class, we have been discussing about acute lymphoblastic leukemia. And we have seen this acute lymphoblastic leukemia for all its concepts, treatment, management, drugs used, etc. And today we shall discuss about one more important type of leukemia, so that is called as chronic lymphocytic leukemia. The first one is acute and this is chronic. The chronic lymphocytic leukemia is also called as CLL. Now, acute lymphoblastic leukemia is very common in children, whereas chronic lymphoblastic or lymphocytic leukemia is very common in adults. Especially the chronic lymphocytic leukemia is very common in European countries, USA, etc. Less frequent in the rest of the world population. Compared to the Europe and the USA, in other parts of the world, this is less frequent. The commonmost age for this chronic lymphocytic leukemia is 60 years. It is very common in males than females. Of course, we know that this is an incurable disease. It tends to run chronic and fluctuating course. So this will run in a chronic course, and as well as this is having a fluctuating course. Now, if you look into the definition of chronic lymphocytic leukemia, this is also called a small cell lymphoblastic leukemia, or it is also called as peripheral cell leukemia of both B cells and as well as T cells, which is characterized by monoclonal proliferation of the immunologically incompetent, slowly dividing mature B and as well as T lymphocytes. The monoclonal proliferation means that is group of the cells produced from a single ancestral cell by repeated cellular replication. How to do the diagnosis of this? Monoclonal proliferation. If the monoclonal B cell count is more than 5 to 10 to the power of 9 per liter, 5 into 10 to the power of 9 per liter, then it is called as monoclonal proliferation. So this monoclonal proliferation is one of the important point in chronic lymphocytic leukemia. WHO classification of chronic lymphocytic leukemia is chronic peripheral B cell leukemia or lymphoma, also called as small cell leukemia, chronic peripheral T cell leukemia or lymphoma, which is also called as small cell T cell leukemia. Now, if you are looking into the pathology of the CLL, CLL is a slowly growing tumor. CLL or small cell leukemia, there is increased tumor cell survival seen to be more important than the tumor cell proliferation in the pathology. What is important is increased tumor cell survival seem to be more important than the tumor cell proliferation in its pathology. Proliferation is not very important, but increased tumor cell survival rate or period, so that is very important. CLL and SLL contains high levels of BCL2 protein that inhibits the apoptosis. That means tumor cell will not be destroyed, it will be surviving more because there is inhibition of the apoptosis. The chromosomal deletion leads to the loss of the genes encoding the microRNA that are negative regulators of BCL2 protein. Signal generated by the B cell receptor or the surface immunoglobulin cause the expressions of the gene that promote the survival of CLL or SLL cells. Accumulation of the tumor cell causes the suppression of the normal B cell function. So this is the total pathology of a CLL. Looking into the clinical symptoms of CLL, many times patients are asymptomatic. Anemia will be there. Yes, anemia will be there because bone marrow is get affected. So due to the progressive replacement of the bone marrow cells by the tumor cells, hypersplenism and autoimmune hemorrhagic disorders will be seen. Splenomegaly, yes, splenomegaly to remove the immature RBCs and WBCs, etc. So splenomegaly will be there, and also hepatomegaly will be there. Hemorrhagic presentations will be there in case of CLL also, bleeding, thrombocytopenia, etc. Susceptibility for infection, that is always there. Bone marrow cells are replaced by the tumor cells and they cause the hypogammaglobulinemia. The lymph nodes are also get enlarged. Superficial and common finding, that is lymph node enlargement. Lymph nodes are usually non-tender and symmetrically enlarged and discrete. Looking into the lab investigation of CLL, we have to go for the peripheral blood picture. Normocytic normochromic anemia will be seen because it is not what I mean to say iron deficiency anemia. This is a bone marrow anemia. Therefore, normocytic normochromic anemia with the mild and moderate level will be seen. Then TLC, very important, increased up to 50,000 to 2 lakhs microliter. Typically, more than 90% of the leukocytes are mature or small cell lymphocytes. Basket-like cells, Mudge, or the basket-like cells, that is degenerated forms of the leukocytes, are seen due to the damaged nuclei. That is also one of the characteristic finding, basket-like cell. Platelet count is normal or sometimes moderately reduced. Looking into the bone marrow examination, 4 types of the infiltration has been seen. Yes, one is interstitial, another one is nodular, diffuse and mixed. What do you mean by interstitial? Interstitial is individual neoplastic cells are found interspersed between the hemopoietic cells and the fat, and that is called as interstitial infiltration. Nodular infiltration is well defined round and ovular aggregation of the neoplastic cells are seen that are non-paratrabecular, and diffuse infiltration is extensive replacement of both hemopoietic and the fat cells, and also the bone marrow architecture is effaced and looks like a packed one. And last one is mixed, where all the 3 types are seen. Looking into immune phenotyping provides the definitive diagnosis. Immune phenotyping should be done in all the cases before beginning the therapy. CLL cells usually express a membrane phenotype of early B cells. So here the tumor cells express CD19, CD20 quite weaker, whereas CD5, CD23 and weak surface membrane immunoglobulins are get expressed. So these are all diagnostic. A single light chain is expressed on the surface of the tumor cell, kappa or delta. Looking into cytogenetics of a CLL, there is no single cytogenic abnormality specific for chronic lymphocytic leukemia. The common abnormalities includes 13q or 11q, trisomy, 12, 17p and complex abnormalities. Some chromosomal abnormalities may be seen in 11 chromosome Q and 17 chromosome P are associated with the poor outcome. Immunological studies of CLL, now hypogammaglobulinemia is seen in 2/3 of the cases. Many become severe as the disease progresses, and 5% of the patients, the YUM band will be seen. YUM band refers to monoclonal protein. What is the prognosis of CLL? Yes, diverse disease in terms of clinical behavior. Over the years, the variety of the disorders will be seen, and they are used to predict the prognosis. Staging of the CLL, 2 systems are existing. One is RISE system, commonly used in the United States, and BINET system, commonly used in Europe. What are the prognostic markers? Somatic maturation status of the variable regimen of the immunoglobulins heavy chain. This divides the disease into 2 types. 55% of the CLL have the mutated IgVH, and they have indolent disease and median survival of the person up to 24 years. CLL have the unmutated IVGH, and that is IVGH refers to immunoglobulins heavy chain. Okay, so mutated IVGH, and they have aggressive disease, and the median survival of the person is 8 years. So presence of the chromosomal abnormalities like deleted 3q 14.3 is good, whereas deleted 11q 22.23 is poor, trisomy 12 is intermediate, and deleted 17pb is a very poor prognosis. Now what is the treatment? We know that incurable disease, the treatment is only conservative. With optimal treatment, that patient can lead to a normal life for several years. Aim of the treatment is symptom control rather than achieving the normal blood count, and many patients do not need any treatments. The treatment is given for the troublesome enlarged lymph nodes or the spleen. When constitutional symptoms such as weight loss, loss of appetite, etc., suggest the bone marrow depletion. Looking into chemotherapy, these are the common drugs used like fluoroderbyn, chlorambucil, cyclophosphamide, steroids, rituximab, and radiotherapy. So this is all about CLL. In the next class, we will look into acute myeloid leukemia. Thank you very much.